Welcome to AETCM. Today we're going to discuss a case about one 44-year-old female who came to her ER with a history of slip and fall followed by fall on her outstretched hand and complaining of restriction of movement over the shoulder region with pain. Shall we begin, sir?
Yes.
So, our initial assessment, patient was conscious, oriented, and she was able to complete one full sentence. And her hands was seen near her body, with which was supported by her other hand.
Okay.
Yeah, on coming to the airway was patent, no secretions noted, and breathing part, respiration, air entry was bilaterally equal, and respiration of 18 per minute, and saturation was 98% maintained in room air. In circulation part, BP was 130 over 70 mmHg, pulse rate of 100 per minute, and all peripheral pulses were palpable. And she had a pain score of 6 out of 10, and we gave her initial analgesis, injection paracetamol was given. And in disability, GCS was full, and pupil were bilateral equally
reacting to light. Okay.
And exposure was also done, sir. So the main history is that
okay, you can continue.
She is a known case of hypothyroidism on thyroxine 75 mg OD. Now complaints of slip and fall on her outstretched hand, with following which she is having restriction of movement on the shoulder region with associated pain. She came to her ER within 1 hour of the incident, and there is no history of any head injury, no history of LOC, vomiting, seizure, or ENT bleed.
Okay, sir. So the things that we have to see, we have an 44-year-old lady who is a known hypothyroid who has come with a history of fall. So this is a trauma patient.
Yeah.
What happened to the cervical spine?
Cervical spine has no C-spine tenderness was noted.
Always remember what would be the fall. Trauma patient, always remember cervical spine. A is for airway with your cervical spine stabilization. B is for your breathing, ventilation, oxygenation. C, circulation with hemorrhage control if there is any hemorrhage. So cervical spine you have missed. You didn't tell in your presentation. So cervical spine very important because we don't know how she has fallen down. We just know that she has a slip and fall. She would have slipped here and fallen by her hand hitting the ground. And what happened to the head? What happened to the spine? Very important. So these all things you should always keep a watch on it. Okay. So now we have an isolated injury to the right shoulder as per your history, right?
Yeah.
Only an isolated injury to the right shoulder. So what are the possible injuries that you can anticipate in this patient? So she has come with an history of fall on an outstretched hand over the right hand or the left hand?
Right hand.
Right hand. So what are the possible injuries by the mechanism of injury? What are the all things you can have?
So during fall on outstretched hand, there are high chance that a patient can have distal radius and
ulnar fractures. So you can just start from here. You can have carpal bones. You can have carpal bone fractures.
Yeah.
So you can have your scaphoid bone fracture. Very common to have lunate dislocation. Very common to have on a fall on an outstretched hand. Distal radial fracture. You can call these or Smith fracture. All those things are very common with your fall on an outstretched hand. Then you come into the elbow. There can be elbow dislocation. Then you can have supracondylar fracture of humerus. Then you have shoulder. We can have fracture with dislocation or just a dislocation, or you can have a brachial plexus injury depending upon the extent of force by which the injuries has happened. So all those things you need to keep in mind. Then you go upstairs, then you have clavicle fracture, chance of clavicle fracture. And if the patient had a very bad fall and all, cervical spine injury also need to be considered, and head injury also. So these are the possible fractures. Very rarely you can have roof fractures. If they have fallen and the chest would have hit the ground, we can have the roof fractures also. So these are our anticipated injuries after knowing the mechanism of injury. Whatever mechanism we have described, these are the possibilities. Now the patient is here, is A, B, C, D is fine. You have given her analgesics and she is in front of you. And she's holding her hand internally rotated, and the opposite hand is supporting her. So this is the classical position that you will see in a shoulder injury, especially shoulder dislocation. So sometimes they will not be able to touch the opposite shoulder. This all history is very important. Now you start with your examination of the joint.
In examination, in inspection, the right upper limb was minimally abducted and
Minimally abducted. So
externally rotated.
externally rotated. Okay.
And she was elbow is flexed and she was holding her right hand with the left hand
Okay,
supporting.
something like this
Yeah.
was her position. So she's not able to internally rotate and not able to touch the opposite shoulder. Okay.
So shoulder exposure was done and shoulder contour was kind of lost, sir.
Okay. So the shape of the normal shoulder is lost. Okay.
In palpation, tenderness was noted over the right shoulder region, and the head of humerus was seen in the infraclavicular region.
Infraclavicular region. Okay, fine. So that is your palpation. Then
In movement, examination of the movement was painfully restricted.
okay, all the movements, all her movements are painfully restricted, both active as well as passive movements. So if there is one restriction, don't try others because the patient will have more pain, and sometimes by this movement, if there is a fracture, the distal segment or a proximal segment can dislodge and can cause a neurovascular injury. So that part you should be very careful.
Neurovascular examination, distal pulses were palpable. No, there was no anesthesia, no sensation loss over the axillary C5 region.
All those dermatome, there was no dermatomal loss. So she don't have any at present from your clinical examination. The most important thing, you have done your inspection, you have done your palpation, then you have to look in for the range of movements, both active and passive, which is painfully restricted. Then you have gone for your distal neurovascular deficit, and any special test is there for shoulder joint. But in this patient, it is not possible. Suppose you are dealing with an rotator cuff injury, you have to do all the special tests. Can you name few?
We can do a Dugas test, which we look for whether the patient can adduct the shoulder and touch the opposite shoulder. There is Hamilton ruler test, in which if at all there is shoulder dislocation, the ruler can touch both the lateral epicondyle and acromion.
Acromial.
Then
acromion tip of the acromion.
Yeah. Then there will be Callaway's test, in which the vertical axillary diameter will be increased.
Okay. So these are the name tests, but unfortunately, we will not be able to do any of these tests for a patient with a shoulder injury, especially with the shoulder dislocation. It's very difficult. So what we can do is that we can most importantly look for distal neurovascular deficit that you have done. You have looked for your radial artery, your brachial artery, ulnar artery, all the sensation, all the upper limb dermatomes you have to do. So what is the most common nerve injury anticipated with this type of injury?
Axillary
nerve injury. So if the patient is having axillary nerve injury, what will be the deficits that they can have?
Shoulder butt sign is the main deficit we see. There will be loss of sensation over the deltoid region. Then
muscle
will
okay. So what will be the abduction? All those movements will be significantly restricted. So we have to look in for definitely a shoulder dislocation. You have to look in for the axillary nerve injury. Mandatorily you have to look in for, but maybe after reduction it might go away. So one is axillary nerve injury, but they have significant pain. You might not be able to ask them to do an abduction, but you can always look in for the dermatomal supply over the deltoid, whether that regimental badge area is having adequate sensation or not. Fine.
Yeah. Then
so you have a patient, we'll just brief it out. We have a patient who has come with a history of fall on an outstretched hand. You have done your shoulder joint examination, but most importantly, you have to examine other joints also. We can miss a subtle fracture. We can miss a small scaphoid fracture, can be missed. So we have to do all the possible joints that can get injured with this injury. You have to examine that joint also. That is mandatory. So we have to do your elbow examination. You have to do your any tenderness over the radius ulna, scaphoid tenderness over the anatomical snuff box. All those things you need to look in for. So that you have to tell, you have to do, and you have to while presenting, you have to tell that also. So now we have given an analgesics, and her pain has subsided to some extent. But unless and until we are not reducing this, the pain is not going to come down. So what will be the next plan of action for her?
So the next plan of action will be to get an X-ray imaging to know whether is there associated, if at all it's a dislocation, and if there is an associated fracture associated with it.
So what all views you want? Again, that is very important. Which all views you wanted to get for a shoulder injury?
So for shoulder injury, we have to get AP view, anterior posterior view, and also scapular Y view.
So, and that is the most common one that we need to ask in for. So, you need to have clear instruction to the radiographer that you are suspecting a shoulder injury, and you are suspecting a possible shoulder dislocation. So you want to differentiate whether it's an anterior dislocation or a posterior dislocation or inferior dislocation. So these are the information that you needed. So you have to give them and you have to ask for those specific views. So as you said, you can ask for a simple lateral view, AP view, or a shoulder axillary Y view also can be asked for. So that is a major requirement. So what is the X-ray finding?
X-ray was showing a dislocation of the shoulder in anterior-inferior.
Antero-inferior, that is the most common sort of dislocation. Antero-inferior dislocation that you had seen in her, okay.
And there was no any associated fracture.
There was no evidence of any other fracture. Okay. So we have a patient again who has come with a possible antero-inferior dislocation with no neurovascular injury, and she don't have any evidence of fracture as in the X-ray. So that's it. Okay. Now, how will you proceed?
So the further management will be to reduce the dislocation. So we can do as she will be having lot of pain. We have to do is under procedure sedation.
Okay.
And the dislocation has to be reduced.
Okay. Now for procedural sedation, how will you plan? 44-year-old patient with hypothyroidism in this background. So how will you classify her and what all drugs you will select? Procedural sedation again, it's a big thing. So you have to be very cautious. You can't give all drugs to all patients. So you have to select your drugs properly. Which drug you want? What is the idea behind your procedural sedation? What are the key things that you need to look in for?
So in procedural sedation, our main idea is to have analgesia and anesthesia.
Okay.
In which so patient is having a known case of 44 already, which is near normal age. There is
no other major risk
factors are there.
So you have to, as we say, you have to risk stratify her. What is her risk? You can ask for the American ASA classification. You can put her 1, 2, 3 or 4. So she will come under ASA category 1. So she don't have any major risk factors. So after that you need to select an agent. How will you select an agent? Next thing will be the hemodynamics of the patient. Hemodynamics of the patient is the next thing. So you have categorized the ASA. Now you have gone for the hemodynamics of the patient. Suppose the patient is in a polytrauma victim. So there is a lot of hemorrhagic blood loss. And now the patient is in hypotension. So we cannot use all the drugs. So, but in this case, it's an isolated injury. But hemodynamics is the next most important aspect. So, you have to select a drug which is not affecting or which is supporting the hemodynamics of the patient. Drugs like ketamine, which will increase the circulation, which will help in increase the blood pressure. So, even the patient is in hypotension, we can use ketamine. So, ketamine again has got very good analgesia, sedation effect. The only thing about ketamine is what? What does it do?
Raise the ICP?
No.
Respiratory?
No.
Dissociative
anesthesia. After you are given ketamine and just ketamine after 45 minutes or 1 hour, the patient is telling something to you and you are not able to understand what is it. So you have to prevent dissociative anesthesia by giving a benzodiazepine along with ketamine. So always remember when you are using ketamine, you have to use an benzodiazepine, small dose of benzodiazepine followed by the required dose of ketamine need to be given for a procedural sedation. Otherwise, the patient will have dissociative anesthesia. So the key things in procedural sedation, first thing, what is the risk factors of the patient? What exactly you want? Certain times procedural sedation, if you are planning for shifting for a CT, that we can't exactly call as a procedural sedation, but just shift for CT, we doesn't need any analgesia, we just need some sedation. But here you need to have a sedation as well as analgesia. So you need to select an agent which has got both these properties. So ketamine is an ideal example for this. Ketamine is a drug where you have got very good sedative effect, very good analgesic property also. Only side effect is that it can have dissociative anesthesia that you can tackle by giving a small dose of benzodiazepine. So risk factor, ASA classify the patient, hemodynamics of the patient. So these 3 things you do, you connect to the monitor, check the vitals. It should be a continuous monitoring of your vital parameters has to be done. And post procedure also, you need to have a continuous monitoring for another 30 minutes to 1 hour till the patient is off your anesthesia agent. So what are the possible agents that you can use in an ED? Which are the group of drugs that you can select for procedural sedation?
So we can either use ketamine can be used associated with the benzodiazepine, or else we can use propofol, fentanyl, then you can use etomidate.
So we can start with each drugs. Okay, ketamine. Ketamine we said regarding dissociative anesthesia. Raised ICP was there previously, but now there is no major issues. How much dose you need of ketamine?
Ketamine 1 to 1.5.
That is the induction dose. So we doesn't need an induction dose. Half of the induction dose is only needed. Induction dose is for your rapid sequence intubation. So half of your dose for your induction, maybe 30 mg should be sufficient for a 60 kg infusion. So ketamine with that small dose of benzodiazepine plus positive things, it can be no hemodynamic compromise, and it has got very good anesthesia as well as sedative property, analgesic property and sedative property. Next drug you said is fentanyl. So what are the problems with fentanyl? Negatives and positives.
Fentanyl, as there will not be any rise of fentanyl only causes the analgesia.
It has got anesthetic property also, but as an individual agent, it is very difficult. But being an opioid drug, it has got some sedative properties also. But we need a better sedative agent. Maybe you need to mix it with another benzodiazepine. So again, fentanyl, it can cause hypotension. So that is the other problem with fentanyl. But usually hemodynamics, a stable patient like this, we can still try with a small dose of benzodiazepine with fentanyl. How much dose you need?
0.5 to 1.
0.5 to 1 microgram per kg you can give fentanyl. So next drug is etomidate. Advantages and disadvantages.
Etomidate is stable.
Etomidate, but problem it has only have sedative property. It only have anesthesia property. It is not an analgesic at all. So when you are using etomidate, you have to have an other agent which can have an anesthetic property, analgesic property like fentanyl you need to add on with it. Okay. Then fentanyl, propofol. You said regarding propofol. Advantages of propofol, disadvantages of propofol.
Propofol can cause hypotension.
Propofol can cause hypotension. Some patient it can cause allergy also. So what you can do, you can combine, but it has got very good anesthesia property. So you can give ketofol. What is small dose of ketamine and propofol combination you can use. So that is the advantage of ketamine with propofol. So that all depends upon your center, how you are comfortable with these drugs, how the staff nurses also has to be comfortable. They should not just push propofol like that. They should be used. They should be using propofol frequently. Then only you will be able to give these drugs. So ketamine, propofol, etomidate, benzodiazepines, midazolam, like benzodiazepines like midazolam, all these drugs can be used, but you have to see risk factors and hemodynamics and what is your need, sedation and analgesia. So you have to select an agent accordingly. So here what you did for this patient?
Here we went with the ketamine and midazolam, sir.
Ketamine with midazolam, which is a reasonable combination, which has got anesthesia and a sedative property and analgesic property, and also to prevent dissociative anesthesia, you are given midazolam also. Okay. So what? Now we will come to the procedure. Yes.
So in procedure, we usually do the procedure as the anterior inferior dislocation. We will be doing a technique in which coaches
there are lot of techniques. Lot of techniques are there. Each orthopedician may have his own technique also. But what is the most commonly, widely and easily acceptable one is what you said is the caucus method. So can you elaborate on that?
In which the patient is lying supine with the elbows flexed, and the examiner will be using his hand and catching hold of her both elbow.
Arm. You can show on our Abhin. Yeah, Abhin is sitting there. You can just demonstrate. How?
So elbow will be flexed.
Okay.
Such. So in which elbow will be flexed and slightly abducted and externally rotated.
Okay.
So we will be giving traction in the arm. In that during that time itself we will be externally rotating.
Traction, externally rotating. Yes.
And also abduction will be done during simultaneously. And we will be doing this continuously till
you feel a click or the patient have significant relief of pain.
And following which we will do internal rotation and keep the arm in the near the
chest
and also followed by immobilization.
So it's just a simple test. What you can do, we can do a traction, external rotation, abduction and internal rotation. So that is a tier. That is a mnemonic that we have all learned. So traction, external rotation, abduction and rotation. Rotation is internally you rotate and you give an immobilizer for the support. That's a simple thing that you can do. There are a lot of other Hippocratic methods. There are a lot of methods that you have to put the foot on the axilla and you need to pull. All these methods are there. But the most commonly used and easily understandable one is the traction, external rotation, abduction, and rotation method. So, which usually, because since she's happening for the first time, you might find some difficulty. But if a patient is having recurrent dislocation, it might come far easier, much more easier. But maybe the first time it will take some time. So maybe you need to do this procedure. You need to try this traction thing for a longer time. But when you give a good anesthesia and sedation, the patient can tolerate. Suppose this fails, what you will do?
We can go on with one more another technique.
Okay.
Where we'll try another technique which can
we can try to reduce the shoulder joint. Of if still it is fail, you need to take in for the theater and you have to give proper anesthesia and you need to reduce the shoulder dislocation. And after once the shoulder is immobilized, what will be the instructions that you will give to her? What all things you need to do? You need to get check X-ray. Then soon after dislocation being reduced, you look for the distal neurovascular deficit. What is the whether there is any deficit if there was previously, or maybe after dislocation, if not you have done properly, reduction is not done properly, she can develop right now. So whether that is any neurovascular deficit is there or not, then you can take a check X-ray and see whether the dislocation is reduced or not. And you need to continue the immobilization for another how long? How long you will advise her to review?
2 weeks.
2 weeks, that's the usual thing. They can come back. If needed, we are having any rotator cuff injury or anything else, we can evaluate during that time. After 2 weeks, maybe an MRI might be needed for the evaluation of that. So that is the usual thing. Anything else that you need to tell for this patient?
Complications patient can get axillary nerve injury and also can cause Bangart's and Hill-Sachs lesion.
Bangart's and Hill-Sachs lesion, that's the other possibility that after MRI we will be able to know it better. But always remember that this patient is on a thyronome. One thing that you need to check in is whether this patient is taking calcium and vitamin D supplements. The patient is on thyroxine, that itself can cause osteoporosis. Already 44 age, she is going into her menopausal age group. So she already can have all these deficiency, but taking thyroxine again can increase the chance of hypocalcemia and osteoporosis. So chance of fracture should be more in her. Luckily, she didn't get any fracture at this point of time. She's not taking any of these replacement. You can ask her, and maybe after a proper physiotherapy also might be required once the MRI or anything is done, and we have ruled out any major soft tissue injury. Need to have a proper strengthening exercises for the shoulder joint is mandatory. Okay. Anything else you need to add on?
Yes.
Okay. So we'll just brief it out. We had a patient who had come with a history of fall on her outstretched hand. She has an isolated shoulder injury. There was no compromise in the airway, breathing or circulation. And there was an X-ray taken, showed an anteroinferior dislocation. And we had given her adequate painkillers. And after that, we have gone ahead with that procedural sedation. She didn't have any major risk factors. So we went ahead with midazolam with ketamine, and with the reduction of traction, external rotation and abduction, and again internal rotation, this thing got reduced, and you have given an immobilizer, and you are asked her to review after 2 weeks. Okay, fine. Thank you.
Okay.